insulin pump therapy.
Okay.
I'm going to talk to you about diabetes mellitus. It's a metabolic disease involving inappropriately elevated blood glucose levels. It has several categories, including type 1, type 2, MODY, gestational, neonatal, and secondary causes due to other health problems, steroid use, etc. Type 1 diabetes mellitus is characterized by the destruction of beta cells in pancreas, typically secondary to an autoimmune process. The result is the absolute destruction of beta cells, and consequently, insulin is absent or extremely low. Diabetes is well known about its complications. Complications involve microvascular, macrovascular, and neuropathic issues. Microvascular and macrovascular complications vary according to the degree and the duration of poorly controlled diabetes and include nephropathy, retinopathy, neuropathy, and cardiovascular events, especially if it is associated with other comorbidities like dyslipidemia and hypertension. Approximately 2/3 of those with diabetes will die from a myocardial infarction or stroke. Fast glucose of more than 100 milligrams significantly contributes to the risk of cardiovascular disease, and the risk can develop before hyperglycemia. Treatment of diabetes requires a multitude of interventions for successful management. Education and patient engagement are critical. Patients have better outcomes if they can manage their diet, exercise regularly, and monitor glucose. Ideally, glucose levels should be maintained at 90 to 130 milligrams and HbA1c at less than 7%. While glucose control is critical, excessively aggressive management may lead to hypoglycemia, which can have adverse or fatal outcomes. It was in 1993 when this CT research group announced that the higher the mean HbA1c, the bigger is the relative risk of progression of diabetes complication. The intensive therapy gives us a gain of 15 years of complication-free living compared to conventional therapy, and a gain of 5 years of life expectancy compared to conventional therapy. And some years later, we saw that the higher the blood glucose, the bigger the hospital mortality. Options in insulin therapy for type 1 diabetes are the multiple injections, the insulin pump, artificial pancreas, and implant transplant. Over time, most type 2 diabetic patients will need insulin to control glucose. Basal insulin, sometimes called background insulin, the insulin working steadily throughout the day. Bolus insulin, it's a single dose of insulin given for one of two reasons. It's the meal or snack bolus, insulin dosed when food is eaten, and the correction bolus, insulin dosed when blood glucose level is too high and needs to be corrected. Insulin delivery methods are the insulin syringe, the insulin pen, the insulin pump, and the jet injector. Here we can see, in this picture, we can see the plasma insulin levels in a healthy person. As you can see, the levels of insulin are low but not zero before meals, and they are increasing after the meals. This is where we use the basal bolus insulin concept in diabetic patients. Basal insulin suppresses glucose production between meals and overnight. Bolus insulin limits hyperglycemia after meals. In this picture, we can see the results of the basal insulin and the bolus insulin. Another picture. So the bolus insulin, it's rapid-acting insulin, and the basal insulin, it's long-acting insulin. Insulin pump. We use only rapid-acting insulin, not only for the bolus dose, but the basal insulin during the day. Before meals, the patient injects bolus doses of rapid-acting insulin. This picture is with basal and rapid-acting insulin, and this is with insulin pump. Insulin pumps have the same basic components and deliver a pre-programmed basal rate. They are programmed to give bolus insulin on demand for food or high blood glucose levels. The components are a reservoir to hold 3 days worth of insulin, a motor to push the insulin into the patient, a menu-driven operating system with battery and casing, and an infusion set, tubing, to get the insulin from the reservoir to the patient. Here we have the infusion set who contains the cannula, the flexible tubing, the insulin pump with the reservoir, the motor, and the display monitor. Advantages of pumps. Insulin pumps have multiple and temporary basal rates. They have multiple basal patterns. We can avoid long or intermediate acting insulin, more precision in insulin delivery, more accurate dosing for food intake fractions of a unit bolus calculators, easier correction of high blood glucose, weight management, improved glucose levels and reduced HbA1c, lifestyle flexibility, fewer injections. The patients have the tools they need on their body all the time, decreased hypoglycemias, less anxiety trying to keep on schedule, increased control with exercise, and improved quality of life. Disadvantages of insulin pumps are the risk of diabetic ketoacidosis if insulin delivery is interrupted. It's a constant reminder of diabetes because it's all the time attacks on the human body. There are a lot of problems with privacy because it is visible in public and may promote unwanted questions. And we have also skin and infusion set issues, missing boluses, weight gain, cost, and of course, they are machines which can fall and break. Indications of insulin pump therapy are the inadequate blood glucose control, the frequent hypoglycemia, the Down phenomenon, exercise, pediatric patients, preconception or pregnancy, healthy lifestyle, shift work, gastroparesis, and I believe that every diabetic patient type 1 can use the insulin pump. Patient selection criteria, the patient must be motivated to take insulin, must be willing to monitor and record blood glucose, minimum of 4 times per day, willing to quantify food intake, willing to follow up. He must want to improve glucose control, must desire to live a more normal life, has family support, ability to solve some problems, and of course, realistic expectations. The second part of this presentation is the continuous glucose monitoring. CGM changes the way we interpret glucose data. Self-monitoring of blood glucose provides only a snapshot, and many patients don't reach targets. CGM provides real-time information about current glucose concentration, feedback about the effectiveness of intervention, warnings when glucose concentrations become intentionally high or low. These alerts can be used preemptively to avoid hypo and hyperglycemia. These black dots are the fingertips glucose meter, and the red line is the blood glucose during the day. CGM components. CGM have a sensor-thin flexible wire inserted beneath the skin into the interstitial fluid space using an introducer needle, a transmitter seated in a plastic pod or clinked into the side of the sensor, and a receiver, either pump, phone, or separate. The sensor and the monitor. CGM systems display and record glucose levels throughout the day and night, provide direction and rate of change of glucose information to help maintain the glycemia, provide alerts if glucose is traveling outside of targets, measure glucose in the interstitial fluid space, and use an electrochemical process of sensing glucose. Benefits are the alerts for lows and highs. The rate of change of alarms help prevent the lows and highs. Identify trends for dose adjustments. Immediate feedback on how changes in diet, exercise, and insulin after affected blood glucose. They have decreased variability, so less hypo and hyperglycemia. Limitations are the alarms. They are annoying and disruptive. They cannot always be heard, they are expensive, time-consuming, and must be worn frequently to get benefits. People who choose CGM for better glucose management, avoiding frequent hypoglycemia, preventing hypoglycemia and awareness, understanding the effects of particular foods on post-meal blood glucose, overnight safety, especially for those who live alone, frequent driving, travel, high-risk professions, young children unable to report hypoglycemia, diet control before and during pregnancy. The last part of the presentation is the artificial pancreas. Artificial pancreas can deliver insulin based on sensor readings using an algorithm to either increase or decrease the person's insulin as long as certain conditions are met. They all require input when the person eats carbohydrates. They still require sight and sensor changes, and thicker sticks may still be required for calibration and algorithm updates. Require more training and work on the part of the patient and the healthcare team. So we have an insulin pump, a continuous glucose sensor. The sensor sends the blood glucose result to the insulin pump, which uses an algorithm to inject some units of insulin to the human body. What do we need for fully closed loop? Faster rapid active insulin, better sensors with improved accuracy and less lag time, consideration of the use of other hormones, and algorithms to integrate all of the above that can account for acute changes in activity levels and hormonal changes. Thank you very much.